Hey guys, so it's a long video covering 50 MCQs from General Anaesthesia, which can be asked in NEET SS exam. Hey guys, so it's a long video containing 50 MCQs from General Anaesthesia, which can be asked in NEET SS or any other examination. So we will directly proceed to the MCQs. First question. The device on anesthesia machine that most reliably detects the delivery of hypoxic gas mixture is dash. A. Fail-safe valve. B. O2 analyzer. C. Second stage O2 pressure regulator. D. Proportion limiting control system. So from the question, they're asking which part of the anesthesia machine can detect the hypoxic gas mixture. So it has to measure the oxygen. So the direct answer is O2 analyzer. Others can measure the pressure difference, whereas the O2 analyzer is the only device in the anesthesia machine which can measure the hypoxic gas mixture. That is the percentage of the oxygen. So the answer is B, O2 analyzer. Coming to the next question, the FRC is composed of dash. Option A, ERV and RV. Option B, IRV and RV. Option C, inspiratory capacity and vital capacity. Option D, expiratory capacity and tidal volume. So you should, whenever one question will be asked in NEET SS, pakka from this diagram which I'll be showing in the next slide. So the answer for this is, that is functional residual capacity is composed of option A, that is expiratory reserve volume with residual volume. As we can see in the graph here, so this is the tidal volume, this is the IRV, inspiratory reserve volume. Tidal volume plus inspiratory reserve volume is inspiratory capacity, and this is the residual volume. Along with the ERV, it makes the functional residual capacity. Whereas the tidal volume along with the ERV will make the expiratory reserve volume, expiratory capacity. So if we combine all these volumes, it will combine and give the total lung capacity, that is IRV plus tidal volume plus ERV plus residual volume. So the answer for this is FRC is composed of expiratory reserve volume and residual volume. Next question. All of the following conditions may develop when using propofol for prolonged sedation in the ICU. So as we all know, propofol can be used as infusion in ICU for sedation. So they are asking the side effects of propofol infusion. And which of the following is not a component of it? So we have pancreatitis, hyperlipidemia, metabolic acidosis, and adrenal suppression. So propofol infusion syndrome has all these symptoms such as hyperlipidemia causing metabolic acidosis, lactic acidosis, and eventually pancreatitis. But adrenal suppression is not a side effect of propofol. Adrenal suppression is caused by etomidate and another induction agent. So the answer for this question is propofol infusion syndrome has all the symptoms. That is, if propofol has been used as a sedation agent for prolonged time in ICU, it can cause pancreatitis, hyperlipidemia, metabolic acidosis, but not adrenal suppression. Whereas if you are giving etomidate more than one dose, it can cause adrenal suppression. So the answer for this is D. So next question, which of the following beta adrenergic antagonists is a non-selective beta 1 and beta 2 blocker? So we have three generations of beta blockers. First we'll go see the options. Option A atenolol, option B nadolol, option C esmolol, and option D metoprolol. So they are asking which of the following is a non-selective beta adrenergic blocker, that is first gen blocker. The answer is nadolol. We will also see what are the three generations of beta blockers. So first gen is non-selective. So the drugs which come under are propanolol, timolol, pindolol, nadolol, and sotalol. So second generation is beta 1 selective with vasodilation and without vasodilation. With vasodilation, we have nebivolol and acebutolol, whereas without vasodilation, we have atenolol, bisoprolol, and metoprolol. And third generation, which is non-selective with vasodilation, we have this hard selective beta blockers, carvedilol and bucindolol. So the answer for this question is that which of the following is a non-selective beta blocker is nadolol. Fifth question, intraoperative allergic reaction are least common after patient exposure to A. Ketamine, B. Latex, C. Muscle relaxant, D. Hydroxyethyl starch. So we will see which of the following drugs or agents are the things or allergens which can produce allergic reactions, especially in the intraoperative period. We know that latex is a highly potent allergen. It can cause allergic reactions in patients who are allergic to latex, and muscle relaxants are allergic. It can cause allergic reactions who are allergic to it. And hydroxyethyl starch, the only disadvantage of using this colloid is allergic reactions, and many patients who are allergic to animal products or allergic to hydroxyethyl starch. So that leaves us with one choice, ketamine. Whether ketamine will produce allergic reaction, it can rarely produce. So we have to see among the options given here, which of the following is the least common allergen to patient in the intraoperative time. So the answer is A, ketamine. Intraoperative allergic reactions are least common after patient exposure to ketamine, whereas option B, C, D can cause allergic reaction more frequently than ketamine. So answer is A. Moving to question number 6, clonidine is dash. So option A, an alpha 2 blocker. We'll read the options first. Option B, increases the CNS sympathetic response to painful stimuli. Answering. So clonidine decreases post-anesthetic shivering. That is an answer. It can be given orally, intravenously, epidurally, and intrathecally. And clonidine is an alpha-2 agonist, not a blocker. So answer we can choose it as D. That is post-anesthetic shivering. So next we will be going to the advantage of forced propofol over propofol is the absence of A. We all know propofol causes pain on injection. It increases the risk of hypertriglyceridemia, especially if we are giving it as an infusion, and it has the risk of infection, sepsis, or both. And option D is all of the above. So, if you see, propofol had these disadvantages, that is pain on injection, risk of hypertriglyceridemia, risk of infection, sepsis, or both. Then they discovered this Lucedra, that is phosphopropofol, which is water soluble, and because of this water soluble character, it doesn't have these disadvantages of propofol. So the answer is all of the above. The advantage of phosphopropofol is that it has no pain on injection, it does not cause hypertriglyceridemia, it does not have the risk of infection, sepsis, or both. So question number 8, which of the following features of chronic morphine therapy is not subject to tolerance? Option A, analgesia. Option B, respiratory depression. Option C, constipation. Option D, all are subject to tolerance. Although we know the chronic morphine therapy, if given, it can cause tolerance over a period of time. So the analgesia will get tolerated. The respiratory depression will also get tolerated. But this constipation is not subject to tolerance. So the answer is option C, and it can't be subject to tolerance in chronic morphine therapy. Question number 9. Which of the following cannot be considered an advantage of low flow anesthesia? So if you are using low flow anesthesia, obviously you are using less consumption of fuel. So you are conserving fossil fuel. And since less gas is emitted out, there is occurring less ozone depletion. and also not even the environment, the OT environment is also getting less polluted. So it is causing reduced room pollution also. But will it conserve uh, the conservation of absorbent? Matlab, will it uh, make the absorbent use less or more? So if you're using low flow anesthesia, there occurs increased use of absorbent, because now we are not using barium related absorbent, we are calcium related absorbent we are using, and this absorbent gets used more in low flow anesthesia. So the answer for this is advantage of low flow anesthesia is all of the following except this conservation of absorbent, because it increases the absorbent use, it doesn't conserve it. Question number 10. With which of the following inhalational agent is cardiac output moderately increased? Option A, nitrous oxide. Option B, sevoflurane. Option C, desflurane. Option D, isoflurane. So if you see in this question, all these agents are modern volatile anesthetics. That is sevoflurane, desflurane, and isoflurane. And N2O is a traditional volatile anesthetic agent. And it is directly like an odd one out. Like all the modern anesthetic agents does not cause increase in cardiac output, whereas N2O causes increase in cardiac output. Whereas previously used halothane and drugs will decrease cardiac output. So the answer for this is nitrous oxide, which causes a moderate increase in cardiac output. Say for example, this question did not have this choice of nitrous oxide. So we are given with only these three choices, that is sevoflurane, desflurane and isoflurane. Now which one among these will you choose as the answer? So as we all know, desflurane causes mild sympathetic increase in tone. So among the options given, you can mention desflurane as the option, but here clear cut answer is nitrous oxide because it is given in the choices, and all other modern volatile anesthetic agents and those can be omitted easily. So the answer for this is N2O. Next question, 11th. Frozen electrolytes can be stored for option A 1 year, option B 3 years, option C 5 years, option D 10 years. So the ABI guidelines say the electrolytes that is in frozen form can be stored for up to 10 years. So we have two forms. One is if you are adding 40% glycerol to the frozen electrolytes, it can be preserved at minus 65 degrees Celsius. But if you are adding 20% glycerol, then you have to store in minus 120 degrees Celsius for its shelf life. So next question is, this is also from blood and blood products chapter. So the question is, which of the following clotting factors has the shortest half-life? And the options given are factor 2, factor 5, factor 7 and factor 9. So the answer is a direct, which of the following factors has the shortest half-life is factor 7, and it has a half-life of 4 to 6 hours. We all know this vitamin K dependent factors are 2, 7, 9, 10. Those are all short acting clotting factors, and among it, factor 7 is the shortest with a half life of 4 to 6 hours. And which of the following peripheral nerves is most likely to become injured in patients who are under general anesthesia? The options are option A, ulnar nerve, option B, median nerve, option C, radial nerve, option D, common peroneal nerve. So this is a direct one-liner which you can answer if you are seeing our bro series, that is basic revision of one-liner series. So if a patient is lying under general anesthesia supine, supine is the most common position in a patient undergoing general anesthesia compared to other position. So in a supine position, the most common, most likely peripheral nerve to get injured is your ulnar nerve. So ulnar nerve, they have seen it to be most likely injured in a patient who is undergoing general anesthesia. So next is 14th question. a 5-month-old infant is scheduled for an elective operative reduction of a right inguinal hernia. Spinal anesthesia is performed and inadvertently high spinal block has been given. So they are asking the first sign of a high spinal block in this patient, that is 5-month-old infant, would be option A hypotension, option B tachycardia, option C hypoxia, and option D asystole. So among the options given, the first sign of a high spinal block would be hypoxia. Next question. What percentage of a term newborn's total body weight consists of water? So whether it is newborn or adolescent or adult, this total body weight water percentage is usually asked in NEET SS, one question per year, per session. So we have to know all the percentages. So in this we have to see whether it is a premature term or it is a normal fully healthy term newborn baby. So it is a term newborn baby. So the answer is 75%. We will also see other things, that is 80% to 90% in premature newborns and 75% in term newborns and 60% in 6-month-old infants, and in adults also 50 to 60%. So they can ask anything. If it is adult, it is 60%. If it is as adolescent, it is 60%. 6-month-old, it is 60%. Then it reduces. If the age reduces, then the total body water percentage increases. So in term newborn, it is 75%, and in premature newborn, it is 80 to 90%. So next question is a direct onliner. What percentage of a premature newborn total body weight consists of water? So this question was asked in my NEET SS exam, except that it did not have this 80% as choice, it had 90% as choice. So the answer would have been 90%. So in this question, the answer is 80%, as we have already seen in the previous question. Next, 17th question. What is the maximum FiO2 that can be administered to the mother without increasing the risk of retinopathy of prematurity in the fetus in utero? Option A 35%, option B 50%, option C 75%, option D 100%. So this question is a trap for you. So they have asked what is the maximum FiO2, and you know that increase in FiO2 will cause retinopathy of prematurity. So seeing this question, you will think it is not 100%, so it must be among all these three options. So you will mark any option A or option B. Mostly the students will commit the mistake of marking option A, since it is the least FiO2 given in the options. So that should be the maximum FiO2 given, because we all know that increase in FiO2 causes retinopathy of prematurity. So where is the trap given in this question? What is the maximum FiO2 that can be administered to the mother when the fetus is in utero? So administering maximum FiO2 to the mother is not a risk factor for retinopathy of prematurity in the fetus. If you are administering in a newborn 100% FiO2, then it will cause retinopathy of prematurity, ROP, another condition. But if you are increasing it to the mother, then it won't have any side effect in the fetus. That is, FiO2 administered to the mother is not a factor in the etiology of ROP in utero. So this line is taken from Smith's pediatric anesthesia. And so the maximum FiO2 that can be administered, if the mother is needing more FiO2, then you can go even up to 100%. So this is a trap. You should be aware of this. So the answer for this is D, 100% FiO2. 18th question. What is the P50 of fetal hemoglobin at term? So it is not adult hemoglobin. If it had been adult hemoglobin, that is 26C would have been the answer. They are asking about fetal hemoglobin. As you all know, fetal hemoglobin doesn't contain alpha and beta. It contains alpha and gamma globin chains. So the P50 reduces to 18. That's why the newborn is having a higher hemoglobin. And we should also know the adult value of P50, that is 27 mmHg. So this oxyhemoglobin dissociation curve, at least 2 to 3 questions will come in every session of NEET SS. Next, 19th question. Side effects of terbutaline include all of the following except option A, hypertension, option B, hyperglycemia, option C, pulmonary edema, option D, hypokalemia. So we all know terbutaline causes hypotension, not hypertension. It causes hypotension, tachycardia, hyperglycemia, pulmonary edema, and electrolyte imbalance, but it won't cause hypertension. So the answer for this is option A. That is, side effects of terbutaline includes all of the following except hypertension because it causes hypotension. Question number 20. So the cardiac output increases dramatically during pregnancy and delivery. The cardiac output returns to the normal non-pregnant values by how long postpartum? So one question which we have discussed in our obstetric anesthesia MCQ marathon is the cardiac output will be highest during which period? That was auto transfusion time, that is just after the delivery of the fetus. So here they are asking when it will return to the non-pregnant value, whether it is 12 hours, it is 1 day, it is 2 weeks, or 6 months. So the answer for this is it will return to the non-pregnant value directly taken from Kaplan, that is 2 weeks. 21st question. So the intracranial hypertension is defined as a sustained increase in intracranial pressure above what? So we all know intracranial hypertension is defined as ICP above 15 mmHg. There is no second thought to it. So the options they have given are 5 mmHg, 15 mmHg, 25 mmHg, 40 mmHg. If it had been 20, then we can give a second thought to about this question, but they have not given. They have directly given 15 mmHg and that is the answer. Intracranial hypertension is a sustained increase in intracranial pressure more than 15 to 20 mmHg. 22nd question. This is also from neuroanesthesia. The afferent input for somatosensory evoked potential, that is SSEPs, is carried through which spinal cord tract? Option A, spinocerebellar tract. Option B, spinothalamic tract. Option C, dorsal columns. Option D, corticospinal tract. So you have to see whether it is motor evoked potential or somatosensory evoked potential. And we have to see if it is efferent or afferent input. So the answer for this is dorsal column because the afferent input for somatosensory sensations is dorsal column. It is carried in the dorsal column of the spinal cord. By 23rd question, by what percentage does cerebral blood flow, that is CBF, change for each mmHg increase in PaCO2? We know when the PaCO2 increases, the cerebral blood flow increases due to vasodilation because CO2 is a potent vasodilator. But they are asking by what percentage the CPF increases for each mmHg increase in PaCO2. If the PaCO2 is, let us say, 30, and if it is increased to 31, then how much cerebral blood flow will be increased? So it is a direct fact-based question, and the answer is 2%. So if there is increase in PaCO2 from 30 to 31 mmHg, the CBF will be increased by 2%. If it is increasing by 4 mmHg, then it will be increasing by 8%. So they can ask as a case-based scenario also. They will be giving the initial PaCO2 and after the ventilatory settings, the PaCO2 was like increase was like 4 mmHg. So how much percent CBF will be increased? So it will be like 8%. 24th question. Which of the following intravenous anesthetic is contraindicated in patients with intracranial hypertension? So they have not asked like traumatic brain injury or something, because traumatic brain injury, then it will be a confusion of choice. For that you have to read exact words from the Cottrell and Millers, which induction agent causes increase in intracranial hypertension and which is neuroprotective. Let me say a hint, ketamine is neuroprotective. Apart from this, you read Millers and Cottrell because we don't have enough time for it. So here, which of the following intravenous anesthetic agent is contraindicated in patients with ICH? Option A, propofol. Option B, fentanyl. Option C, ketamine. Option D, all are acceptable. So the answer is direct first sum question, ketamine, because it increases the ICP. You can see all the questions are easy level questions which I have framed for this first 50 MCQs of our series. And the main thing is you have to understand the concepts of all the 50 questions so that each choice will be formed as a separate question in the final exam. So by reading these 50 MCQs, you can answer like 200 MCQs in the exam. So you are getting 50 concepts from this video. And it is categorized under easy category. On the further videos, you will be going to moderate and difficult categories. I have designed it to be easy because your NEET SS usually contains 50% of the questions will be easy category questions, and 30% will be moderate and 20% will be difficult. So this easy percentage, you should not get it wrong. So the answer is ketamine. So coming back to the question, 25th question. The normal global CBF is dash. Option A, 25 ml per 100 gram per minute. Option B, 50 ml per 100 gram per minute. Option C, 75 ml per 100 gram per minute. Option D, 100 ml per 100 gram per minute. It's a direct answer. That is 45 to 55 ml per 100 gram per minute. The normal global CBF option B, that is 50 ml per 100 gram per minute, is given here. So these kind of fact-based questions, you should not get it wrong. So you have to see our basic revision of one-liner, that is Bro series, to register it in your mind and revise before the exam so that you don't get these questions wrong. Because if you get wrong answer in this question, then your mark will fall drastically and your rank will fall drastically in the NEET SS exam. The answer is option B. So 26th question. Lower and upper mean arterial blood pressure limits of CBF autoregulation are respectively. So this we know from our physiology. The options given are 25 and 125, 25 and 200, 40 and 250, 60 and 160. The answer is as easy as option D, that is 60 and 160 mmHg. It can be given as 50 and 160 also. The option given is 60 and 160 mmHg. 27th, which local anesthetic undergoes the least hepatic clearance? So the options they have given are chlorprocaine, bupivacaine, ropivacaine, lidocaine. Even if you don't know the answer, you know these two are long acting and this is short acting and this is very short acting. So which undergoes least hepatic clearance is chloroprocaine. And this is a direct one-liner. So next we have 28th question. Listen carefully. So they are asking, the snap felt just before entering the epidural space. If you are putting the epidural needle, you will be passing through the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. So they are asking, the snap is felt in which? The loss of resistance you will be getting while epidural now. So that snap is felt in which ligament? So it is a direct question, that is ligamentum flavum, because it is thick and it only produces the snap before entering the epidural space. Answer is B, ligamentum flavum. Next question, 29. These definitions, Indian Association of Pain Definitions, IASP, Indian Association of Society of Pain Association, has given many definitions, international. And these definitions are very important. And in my NEET SS exam, when I applied in 2024, this question was asked, that is, allodynia is defined as. After knowing the answer, you can easily tell, this is the answer. But in that exam stress, you will be confused and all the options will look similar to you. Let us read the options. Option A, spontaneous pain in an area or region that is anesthetic. Option B, pain initiated or caused by a primary lesion or dysfunction in the nervous system. Option C, an increased response to a stimulus that is normally painful. Option D, pain caused by a stimulus that does not normally provoke pain. So you should memorize its definitions so that you don't get these questions wrong. The answer is option D, that is pain caused by a stimulus that does not normally provoke pain. A similar question that can be asked is hyperalgesia. So hyperalgesia is increased pain response to a stimulus that is normally painful, but now the patient is having increased response. And allodynia was that does not normally provoke pain, now it is causing pain, then it is allodynia. Okay. Next is 31st question. The only technique shown to prevent anesthetic related nerve injury during the placement of peripheral nerve block is. So option A, ultrasound guided regional technique. Option B, trans arterial technique. For example, if you are giving an axillary block, you can go trans arterial and go and hit the nerve. Option C, PNS, that is nerve stimulator guided technique. Option D, none of the above, or you can put it as landmark guided technique. So these are the different types of peripheral nerve block techniques. They are asking which technique has scientifically shown to prevent anesthetic nerve related damage. So you can easily eliminate option D and option B. You will be left out with ultrasound guided regional technique and nerve stimulator technique. Even with nerve stimulator, you can detect the nerves, and even with ultrasound guided technique, nerve injury can be prevented. But they have found in studies and systematic reviews suggest that ultrasound guided regional technique is shown to prevent anesthetic related nerve injury. All other techniques, they have not yet scientifically been proven. So the only technique that has shown to prevent anesthetic related nerve injury during the placement of peripheral nerve blocks is ultrasound. Option A, that is ultrasound guided regional technique. Question 32. Nerves that originate from the sacral plexus include each of the following except. Option A, femoral nerve. Option B, tibial nerve. Option C, sciatic nerve. Option D, common peroneal nerve. So usually you have to know three plexus for the exam. One is brachial plexus, another is femoral plexus, another is sacral plexus. So something will be asked in and around this area. So they are asking sacral plexus. Even if you don't have any idea, you know that sacral plexus in the or the nerves for the posterior compartment, and the femoral nerve is going to the anterior compartment. So that is the answer. Tibial nerve, sciatic nerve, common peroneal nerve, or branches which come from the sacral plexus. So we will see the sacral plexus. So sacral plexus consists from S1 to S5, including sometimes L5 also. And the nerves that are arising are superior gluteal nerve, inferior gluteal nerve, sciatic, that includes tibial and common peroneal nerve, posterior cutaneous, pudendal, and perforating cutaneous nerves. So femoral nerve is not a component of sacral plexus. So next question, 33. Oxygen consumption VO2 is measured in a 70 kg subject on a treadmill at 2500 ml per minute. This corresponds to 1 met, 5 met, 10 met, or 15 met. So they have given the energy consumption, that is 2500. If we divide the 2500 ml per minute by the weight of the patient, that is 70 kgs, we will be getting 2500 divided by 70, that is 35. That will be 35 ml per kg per minute. But we know that 1 met is equivalent to the energy expenditure of 3.5 ml per kg per minute. So 35 ml per kg per minute will correspond to 10 mets. That is option C. So they can ask any question, like they can ask true or false question about mets. They can ask like 1 met is equivalent to 3.5 ml per kg per minute, or they can give a problem like this, like 70 kg subject on a treadmill at 2500 ml per minute, or any other question like this. You should be ready to answer these kind of questions. 34. Accidental injection of air into a peripheral vein would be least likely to result in an arterial air embolism in a patient with which of the anatomic cardiac defects? So this question is related to shunting that we are coming to know from the question. So we will see the choices now. Option A, PDA. Option B, Eisenmenger syndrome. Option C, TOF. Option D, tricuspid atresia. So we have to differentiate whether it is a right to left shunt or left to right shunt. And we know if you are injecting air into a peripheral vein, for example, it will go into the SPC and into the right atrium, and it will cross the tricuspid valve and it will go to the RV. But if there is any shunting from right side to left side, it won't go to the pulmonary circulation, it will directly bypass that and go into the left side, that is the arterial system. So we have to see what are the conditions which will produce right to left shunt and which condition will produce left to right shunt. Among the options given, PDA will cause left to right shunt, whereas all other things, Eisenmenger syndrome, right to left shunt, TOF patients, right to left shunts with a large VSD and severe PS, and tricuspid atresia, if shunting is present, that will be right to left shunt. So all this right to left shunt will cause air embolism, that is arterial air embolism in the patient, but PDA is usually left to right shunt, which won't cause. So they are asking which of the following is least likely to result in a arterial air embolism. The answer is option A, that is patent ductus arteriosus. Next, 35, fifth question. In the adult, the liver is the primary organ for A, hemoglobin synthesis, B, hemoglobin degradation, C, factor 8 synthesis, D, antithrombin 3 synthesis. If you don't pay attention to the choices, you will think that all of the options are like correct answer, but you should think. See, it is just a MBBS level question. Liver is the primary organ for what? Hemoglobin, where it is synthesized from the bone marrow. Okay, option is eliminated. Hemoglobin, where it is degraded, spleen and other reticuloendothelial system, not liver. So option B is eliminated. Factor 8 synthesis. We know that liver is the primary organ for clotting factor synthesis, but there are some factors which are not synthesized from liver, and one of those is factor 8. So all these three options are eliminated, leaving us with antithrombin 3. You should not confuse antithrombin 3 synthesis with factor 3 synthesis, because factor 3, 8 are not produced from liver, but antithrombin 3 is the answer, and the main primary organ for the production is liver. Whereas the factors, clotting factors that are not produced from the liver are 3, 4 and 8. 37. Heparin resistance is least likely in patients with which of the following heritable condition? So the options are A, factor lead-in mutation, B, prothrombin G20210A gene mutation, C, protein S deficiency, D, antithrombin or antithrombin 3 deficiency. So it is a direct one-liner. Heparin resistance is seen in antithrombin deficiency. Okay, next. 36th question. Anticoagulation with low molecular weight heparin can be best monitored to which of the following laboratories? So this question is not even a question from NEET SS, it is also a question from INASS. In INASS, this question is asked in every session. So listen to the question. They are asking, what is the best test to monitor the LMWH levels? So as simple as that. Option A, APTT. Option B, anti-10A assay. Option C, thrombin time. Option D, reptilase time. So this is not heparin, this is low molecular heparin. So we have to find out the anti-10A assay to monitor the anticoagulation caused by low molecular weight heparin. So the answer for this is anti-10A factor assay. 38th question. The onset of delirium tremens after abstinence from alcohol usually occurs in option A, 8 to 24 hours, and that is the most strongly marked option. Option B, 24 to 48 hours. Option C, 2 to 4 days. Option D, 4 to 7 days. So if you see, They're asking about delirium tremors. They are not asking about normal tremors, mild tremors, which occur after abstinence of alcohol that usually starts after 6 hours, and mild tremors will be present on the first day. But they are asking about delirium tremors that will occur 2 to 4 days. Option C. That was a misnomer. Delirium tremens was a misnomer. Option next question 39. Malignant hyperthermia is believed to be a generalized disorder of membrane permeability to which channel? We all know this ryanodine receptor that deals with calcium. So the answer is as simple as calcium. The options given are sodium, potassium, calcium, and magnesium. This is a direct question which was asked in my NEET SS exam also. It was a recall question. So malignant hyperthermia you should read, because what are the triggers which cause malignant hyperthermia is usually asked in NEET SS exam, and the mechanism by which it is uh, acting, and the receptor involved, mechanism involved in malignant hyperthermia, how to prevent it, how to treat it, dantrolene, everything are one-liners for NEET SS exam. Although malignant hyperthermia is a rare condition, it is a potent fatal condition. So you should know about this. So next question, 40th, 10 more questions to go. We have spinal cord of newborns extend to which level? Option A, L1 vertebra. Option B, L2, L3 vertebra. Option C, L4, L5 vertebra. Option D, S1 vertebra. So this question I had included in our pediatric anesthesia MCQ. So the answer is option B, L2, L3 vertebra. So you should also see about the spinal cord and the dural sac levels of newborns and adults. Adults it is L1 and dural sac is S1, whereas in newborns it is S3 dural sac, and we have already seen L2, L3 for newborns. Answer is B, L2, L3 vertebra. Next question is 41. The most reliable method for of determining mild dehydration in a child is by the observation of dash. Option A, dryness of mucous membrane. Option B, skin turgor and fontanelles. Option C, urine output. Option D, blood pressure. See, blood pressure can be affected by any means. So one reliable method of determining mild dehydration in a patient is urine output. Urine output in a child should be 2 ml per kg per hour. If it is less than that, then the patient is having dehydration. 42nd question. Which patients describe their labor pain as being the most intense? Option A, primary who has attended childbirth classes. Option B, primary who has not attended childbirth classes. Option C, multipara. Option C is multipara who has attended childbirth classes, and option D is multipara not attending the multi-prepared childbirth classes. So even if you don't know the exact answer for this, you can guess, you can do the guesswork and arrive at the answer. See, if you are attending the childbirth classes, they will do exercises and they will counsel them that how much pain you will be getting and how to tackle them, how to cope up with the labor pain. Everything will be dealt in the childbirth classes. So if the patient has attended childbirth classes, that is option A, primary attended the childbirth classes, that is ruled out, and multi who has attended the childbirth classes, that is ruled out. Now we are left with option B and option D. Now let us leave the scenario and let me give you a scenario. For example, if I am telling that if I am pricking you in the finger for the first time, then you will be having intense pain. If I am pricking you again for the second time, third time, fourth time, the intensity of the pain on the fourth time will be less when compared to the first time. I know pain is subjective, but as compared to the first time when you are exposed to something, it will be very intense, but second, third, fourth time, it will feel less intense. That is a psychological state, and pain is also psychological and is subjective. So they have found that the primary patients who have not attended the childbirth cases won't have any exposure to the pain that will be undergone during labor. So the most intense pain will be described by option B, that is a primee who has not attended the prepared childbirth classes. 43rd question, anesthetics that decrease the ICP include option A fentanyl, option B nitrous oxide, option C propofol, and option D all of the above. Among the options given, we know that propofol decreases BP and it decreases the MAP and decreases the ICP. Nitrous oxide is controversy. They tell that it increases ICP. Fentanyl has least effect on ICP, and option D is all of the above. So the answer for this is propofol that decreases ICP. 44. Which of the following blocks has the longest duration of action when bupivacaine with epinephrine is administered? Option A, axillary block. Option B, epidural. Option C, local infiltration. Option D, and spinal. So among the options given, if you are administering along with epinephrine, then the peripheral nerve block of the larger nerves, that is axillary, will have the longest duration. We will see the duration also. Why to leave that? So if you are administering bupivacaine with epinephrine as epidural anesthesia, it may last for 180 to 350 minutes. And if it is given as a local infiltration, that is bupivacaine, then it might last for 180 to 240 minutes, little bit less than that. And major nerve blocks such as femoral nerve block, axillary nerve block may last up to 72 minutes. So among the options given, the longest duration of action is axillary nerve block or any other major nerve block. 45. Cardiac tamponade is associated with option A, pulsus alternans, option B, pulsus tardus, option C, pulsus parvus, option D, pulsus paradoxus. Although the options are confusing, the answer is direct, that is in cardiac tamponade, there occurs pulsus paradoxus and it is a misnomer. It doesn't do anything with pulse. It does with the systolic BP. The decline in the systolic blood pressure when we are inspiring is exaggerated in such conditions, such as cardiac tamponade. So it is pulsus paradoxus that is seen in cardiac tamponade. 46. Which of the following drugs should not be administered via endotracheal tube alone? I had kept a mnemonic for this. The ACLS guidelines, they tell which of the drugs can be administered via endotracheal tube, and the mnemonic for that is alone. Leave that. We will read the options. Option A, lidocaine. Option B, NHCO3. Option C, atropine. Option D, naloxone. So if you see, the answer is option B, and the drugs which can be administered via the endotracheal tube is alone. That is atropine, lidocaine, oxygen, obviously via endotracheal tube, naloxone, and epinephrine. And this epinephrine can be administered during CPR if you don't have access also. Next, 47th question. The effect of clopidogrel, that is Plavix, can be reversed with what? Option A, fresh frozen plasma. Option B, factor 8 concentrate. Option C, aprotenin. Option D, none of the above. In your routine anesthesia residency, you would have cancelled some cases telling that the patient had taken clopidogrel 3 days back. The patient did not have the adequate interval time, and you would have asked them to come back after 2-3 days after the time has crossed. That is because clopidogrel is a P2Y12 irreversible inhibitor and it can't be reversed with anything, or else you would have reversed it. Since it can't be reversed with anything, and the option that is the answer here is none of the above. See, whenever you have this none of the above except all of the above as answer, you might think you will read the question and you will arrive at the answer as A. But if they have given like none of the above, all of the above, except these things, you should read that question again. Usually when I am attending the NEET SS exam, I usually read all the questions once, then again I come back and do a revision of all the questions. So when I am doing this revision, if the question is having except all of the above, none of the above, then I will read that question twice, because that can be a trap for us. So you should read that question twice, and it can be also an answer. None of the above, all of the above, these things can also be an answer. So that is a trap. beware of that. 48th question, the P50 for normal adult hemoglobin is approximately dash. Option A 15 mmHg, option B 25 mmHg, option C 35 mmHg, option D 45 mmHg. This we have seen in a question around 10 to 20. One question was there, that was for P50 of newborn. So this is P50 of normal adult, that is 25 mmHg. As simple as that. Next question. Which of the antibiotic below does not augment neuromuscular blockade? Option A clindamycin, option B neomycin, option C streptomycin, option D erythromycin. See, all the questions which you have covered had on mostly like one or two questions, but in your final exam there can be like 6-7 lined questions also. Mostly questions will be like this, but there can be some questions. This question itself they can frame it like a 6 to 7 line clinical scenario, but to make you understand the concept, I have simplified the questions. So the question is, which of the antibiotics below does not augment neuromuscular blockade? Option A is clindamycin, option B neomycin, option C streptomycin, option D erythromycin. So you should know neuromuscular blockade augmentation can be done by certain antibiotics. And among those antibiotics, we have aminoglycosides, that is neomycin, streptomycin, gentamicin, and tobramycin, lincosamide, that is clindamycin and lincomycin. We don't have erythromycin. It is just to confuse you. Erythromycin is a macrolide. That is not an aminoglycoside or lincosamide. Since they have everything mycin in the other drugs, they have just included erythromycin to just confuse you. You should clearly remember that only aminoglycosides and lincosamides can augment the effect of the neuromuscular blockade. And if the patient is already in such, for example, if the patient is in ICU and the patient is taking gentamicin, then it can augment the effect of your neuromuscular blockade. So you should be aware of those things in your practice. And for the question, erythromycin does not augment the neuromuscular blockade effect. 50th question. Have you subscribed to this Anesthesia Couple channel? Option A, no. Then click the subscribe button. Option B is not available for you. I hope you have subscribed to our channel, and if you have seen this video till this, then as a bonus I am giving this PPT in our Telegram channel, and the link is there in the description. Thank you.